because we all know how important our time is. I want to thank a couple people for being here. Number one, Dr. Pacifico. We know it's a requirement that we have a surgeon here, so he's kind of voluntold. Thanks to our new perioperative services educator, Sarah Beth Pope, who is helping me do this morning. Also, if there's any directors in the room, I see Sharon, Beverly, Bonnie, Mary, the other directors, we want to thank them for showing up. Yep, we want to thank them for showing up as well. Also, when we get done today with this drill, everybody hang tight for a few minutes. Joe wants to come in and talk to us for just a few minutes since we're all gathered as a group, okay? So, in the interest of time, like I said, I'm going to speed through this PowerPoint real quick and just hit on the high points. This is a PowerPoint that I got off of the Malignant Hyperthermia website. So I took a lot of stuff out of it, which was mostly focused towards doctors and anesthesiologists, and just kind of hit the high points. I'm not going to read everything. We're all adults. I'll have this available if anybody wants it, and you can read it in detail. Malignant hyperthermia, it's basically do we call it an allergy or reaction?
Genetic.
It's a genetic, disorder. It's inherited, triggered by inhalation agents. The triggering agents are acetylcholine and potent volatile anesthetics. What we do give that are non-triggering agents, ketamine, propofol, anxiolytics, we give those all the time. Clinical signs, muscle rigidity, increased CO2, rhabdomyolysis, marked temperature elevation. Let me just say something about this real quick. So when we're in a surgery in an OR setting and we are everything's going along good, what's the CRNA doing? They're sitting down, right? When something starts getting really out of whack, what's the first thing the CRNA does? They stand up. They get real tense. So that's one thing that you can look for as the circulator or the scrub tech or anybody that's in that room is if that CRNA starts to stand up, something might be going on, so we might need to pay a little more attention. The clinical presentations, the biggest one, especially with children, is the master muscle rigidity. And you can also have the late onset of malignant hyperthermia. That's why it's important for the ICU nurses to be here. So if we do have a patient that comes in and they go to the ICU, this can not only happen in the OR, it can happen in recovery and it can happen in the ICU. It's not that common, but it can happen. We want to do 100% O2, hyperventilate, bicarbonate, dantrolene is our big drug. We want a 2.5 mg per kid. Repeat that as needed, and we're going to also repeat that every 4 to 6 hours in the ICU. This is our Dantrium. We have bottles of it up here. You're going to get an opportunity if you would like to mix that. We have the little spikes. The spike goes into the bottle. We pull the fluid up into the syringe screws down on top of that. Push it. It's super simple because previously we've had syringes with a needle on top, and we've had to push air and suck out, push air and suck out, so we get everything out and get it mixed well. Treatment after the crisis is controlled. This is where it comes up in the ICU. 1 mg per kg every 4 to 6 hours. Watch your blood, your labs and stuff, and then you want to monitor for signs of myoglobinuria and rhabdomyolysis. Prevention. The biggest thing about prevention is identification. So we want to know that a patient has a history of it. If we know that, then we can prepare for it. One way that we prepare is that Mark here, our anesthesia tech, will flush that machine and get all of those gases out of it before we have a patient come in. Preparation, put the disposable vaporizers on. It's got a lot of things that Mark knows with the machines that he does. Management, anxiolytic, propofol, non-depolarizing relaxants. We want to do everything we can do to get this patient through their surgical procedure safely without using those volatile drugs if we know they've got a history. And then that is our emergency therapy for malignant hyperthermia chart. We have one in the OR that is focused on the OR as well. So that was a real quick review. I'll have these slides, the slides that I have online. I can get them out to your leaders if you guys want to read through them in depth. And I can go through them deeper, but I think we'd rather just get to the meat of it, right? All right. So, where's my patient? Patient. My anesthesia provider. My surgeon. My surgeon.
Oh, surgeon.
That way I can make comments without recording it.
Where's my scrub tech?
Scrub tech. Has anybody ever had experience in real life with a malignant hyperthermia? So it's pretty hectic in there. It's pretty fast moving. Once we identify it, things move really, really fast. Our goal is to stabilize the patient. We got to let the surgeon finish the surgery while we get that patient stabilized, and then as soon as we can, get them over to the ICU. Right? So this is going to be a pretty quick run through of this. Okay? So Moss came in today for her lap chole, and when she was in the holding room, she told one of the nurses, yeah, my grandma had something going on with her but I don't know what it was, when she had surgery before. So we bring her to the OR thinking that there's nothing going on. So during the procedure, Dr. Pacifico is sitting there running those little laparoscopic arms around, and Maria notices.
Stand up.
So Maria stands up.
I had to put my book down.
I'm like, oh crap. So she might notice a few things like the patient has a normal heart rate and all of a sudden they're tachycardic. She might notice a couple of degree increase in temperature. Yeah. She might notice a little wacky-dacky going on the monitor machine up there, that we got some arrhythmias going on. So Maria's going to kind of initiate, let's get some people in here.
Hey, something's wrong. This patient seems to be having some symptoms of MH. So we need to call for some backup and
So Beth, you're the circulator?
circulator.
Can I get an anesthesiologist and some extra hands into room 2, please?
So that's your code. Now, we can't just stop the surgery. We have to continue the surgery. We can't close the patient up if they're messed up on the inside.
And if it's ortho, they're still gonna ring your femur the whole time. Your hip will be fixed, but it might be. It's too late. But we would turn off all the triggering agents. If we turn off the follow anesthetic, we wouldn't give any more sucks, hopefully this one. And then we're gonna start drawing up the dantrolene.
Yep. So go ahead and drop the dantrolene. She's continuing to get a little hotter, so what might we want to do? Ice. So somebody go get some ice at the cafeteria. Here comes Sarah Beth. She's a multifunctional circulator here. So two main places that we can put ice that will help to get them cooler quicker.
Head and groin.
Hips and groin.
I was on my way there. I put them between your knees.
One other thing we want to really do is we want to monitor their urine output, right? How do we do that? With a Foley. What kind of Foley? Temperature control, but we also want it to be a three-way. Why do we want a three-way? Because we can flush the cool water through it, and that helps to bring their temperature down as well. Did you get that Foley in?
Yeah, it's in.
How's it going, guys?
Get the dantrolene.
Recording.
Yep.
So we're doing cold fluids for them to irrigate.
Cold fluids, we can do cold fluids. If the wound is open, we can pour cold fluids right on
If
the
Dr.
inside.
Pacifico's in this case, it's done.
It's done.
Starting up the gallbladder.
So we got the dantrolene.
So we're gonna push.
We're pushing the dantrolene. We're trying to get them stabilized.
So, you wanna talk about how this requires a whole lot of,
A whole lot of it.
Yeah.
like,
There's,
a lot.
how many files are in the crash cart, or in the MH box? 32, and sometimes we need every single one of those and even more.
And it's really hard to draw up, and it's really hard to push, and it's time intensive. That's really why you need a whole lot of
Yep.
people in here.
We have to dedicate 2 to 4 nurses just to mix the dantrolene.
And this is what I was talking about with the easier to draw it
Got
up.
a spike, yeah.
Catch. So if you put the spike in here, and then you have some fluid. Draw me up a fluid.
And also during this time, I might be drawing labs, replacing and creating labs that we be treating. We're still cooling, still giving fluids, still monitoring the tachycardia that we
Maybe
have.
treating an antiarrhythmic, rhythm. So
Car-
this you just,
yeah.
basically, you're gonna push.
Yeah. Calcium, monitoring all those things.
It's a lot quicker than pushing and waiting for the air to come back out. Then when you're ready to pull it back up, once you've shaken it and you've got it all mixed up, it doesn't take long. It kinda goes from a dark orange to a transparent. You just turn it over and you suck it right back out. So, compared to previous, before we had these, it would take forever to get a syringe full of dantrolene. Now, it's that fast.
But if we don't have the spike, don't waste time looking for it.
Right,
Just
just get started. They're actually in the anesthesia room up here. I don't know where they are in the other places, but we have them in the anesthesia room. It's pretty easily accessible.
I wonder if you could add those to the MH card.
Are they on it? Anything else?
Ruth on her call.
Yeah, about 2 years ago we added.
Okay, what, anything else you can? I just gotta keep going until, I mean, it can get very long.
I'd like to just say one thing. We had one incident a couple of years ago, and the one thing that everybody took home from it is the first thing you do is call the MH hotline, because they will walk you through step by step. Because reading that little thing the whole time is very difficult if you don't remember all the steps. That MH hotline was amazing. They were very patient. They
Did
said,
you put
do
it on
this next,
like
do this
speaker
next.
or whatever, and
Yeah.
everybody can hear it?
The anesthesiologist was on there and said, do this next, do this next, do this next. And it made it super easy. It was a 3-year-old, so it was really uncomfortable.
We would hope that we would be able to identify these patients before they come to the OR and prevent this from happening, but some do sneak through.
Well, usually it is gonna be somebody who sneaks through. Usually people know, they have a history of high fever, so it's never gonna, usually it's gonna take you by surprise.
Okay, so once we get her stabilized, he finishes up his procedure, gets everything closed, we're gonna ship her over to our ICU friends. Yes,
After the patient's stable, they're in ICU, what are some of the side effects of so much dantrolene? How much,
I mean, it goes through their kidneys, so I would assume that one of the main things that you have to do with that is to, watch their urine output, monitor their urine output, but, at this point, the side effects of not having it
Yeah.
versus having it are much, much worse.
Yeah, your chances of kidney failure
Yeah.
are way higher.
Good question. Anybody else? Any other questions? All right. So I think that's it. Is anybody else want to try anything? Talk through anything? I think we're good. All right. So